Bismillahirrahmanirrahim. Assalamu alaikum. Last year, this news was published in Arab News, which is a leading newspaper in Saudi Arabia, that in 2016, 533,000 accidents happened. And out of these 533,000 accidents, 9,031 people died at the spot. And if you calculate carefully, you will see that after every 1 hour, there is one accident. So this was shocking news for me. Therefore, I conducted my own study. And the main aim of my study was to know the epidemiology of spinal injuries at my own hospital, which is Prince Mohammed bin Abdul Aziz Hospital, and to know the real causes of these spinal injuries and to see how we are managing these cases. It is a prospective study and took 1 year to complete it, and I recruited 160 patients. Our only inclusion criteria was the trauma cases with spinal injury or with spinal cord injury. The old spinal cases, spinal injuries, operated cases, osteoporotic cases, and only simple transfer process fracture were not included in this study. Similarly, simple occipital condyle fracture, sacral fracture, firearm injuries, and pediatric cases were not part of our study. We analyzed this data, and then we reached to some conclusion, and we noticed that unfortunately, majority of our patients were the males, that is 89%. Not only this, but the most productive decade, that is the third decade, these patients were belonging to this decade. And we noticed that 85% of spinal injury were because of only motor vehicle accidents. And in fall, we found a small subgroup in fall that some housemaid tried to run away from the employer house, and they fell down and they got spinal injuries. And we noticed that in motor vehicle accident, drivers and front seat passengers were most vulnerable and susceptible for spinal injuries. Similarly, this is a very alarming slide. I noticed that 98% passengers were not wearing seatbelt at all. And this figure is quite contrary and opposite to the figure which was released by the WHO, that 99% French people usually wear the seatbelt during driving. When I analyzed the spinal levels, I noticed that cervical injuries are more predominant, and the lumbar are second to the cervical injuries. In single level and multiple level were both common in the cervical injury. But in cervical injury, it was the C2 and C7 which were most commonly fractured. In contiguous cervical fracture, I noticed that C6, C7, that is the cervico-thoracic junction, was more vulnerable. In thoracic level, again I noticed the trend of the multiple fracture of the vertebrae. However, it was the D12 which was most commonly fractured. If you see in the multiple level of thoracic fracture, you will see the trend of D11, D12, and L1 fracture, which is basically thoracolumbar junction, which means that this area is most common part of spinal injury. In lumbar level, I found the quite opposite trend as compared to thoracic level. Here you see that single fracture level is more common. L1 was again predominantly involved in spinal injuries. I did not see any consistent or specific pattern in contiguous and non-contiguous lumbar spinal injuries. When I noticed the neurological status, I found that every fourth person of spinal injury is liable or susceptible for any kind of neurological deficit. In neurological deficit, we noticed monoparesis up to quadriplegia, but it was the paraplegia and quadriplegia which were outnumbering. When I analyze spinal injuries with respect to the other body part injuries, I noticed 70% of injuries were associated with some part of body injuries. The management, this is the most difficult part because it is not straightforward theory. Recently, this paper has been published which tells us that how many controversies are still there in management of spinal trauma. Still, we do not have any ideal classification of spinal injuries. Still, we are debating about stability and instability. And still we know, and we still know that there are all burst fracture are not unstable, and all burst fracture do not need surgery at all. And if we opt for surgical management, then the timing is another nightmare. However, this is the current classification system, T-leg system for thoracic lumbar and C-leg for the cervical injury, which we followed. This was our basic principle. A very important slide, please take care of it, that if the mechanically spine is stable and neurologically stable, conservative treatment is must. But if it is mechanically unstable and there is a complete neurological deficit, which means that it is unstable neurologically as well, it should be elective surgery. However, if there is a progressive neurological deficit or incomplete neurological deficit, please go for emergency surgery. In our cases, 40% patient needed some sort of surgical intervention sooner or later. And the main aims of our surgical intervention was to, please give me 1 second only, main aim of the early immobilization and to prevent future disabilities. But what next? Either we discharge the patient or we send to transfer them to the other facility. But according to patients, I have still long way to the go. And the road of recovery is very, very, very narrow and hazy. So our conclusion is RT is major cause of spinal injuries and spinal cord injuries. Seat belt adherence and mobile use is multiplying our problem. And 25% spinal injuries are associated with spinal cord injuries. More than 40% need surgical intervention, and cervical injuries always need intensive care unit. And our recommendation is that in the kingdom, hospital needs more bed in order to cater ever-growing number of spinal injuries, and it is shame really to deal with a spinal injury without any rehabilitation unit. So it is the need of our. Thank you very much.